everybody. Hi, everyone. Welcome to another Rafael Medina subspecialty VMR. So my name is Hui Tin, and I will be your facilitators for tonight's session. So tonight we will be focusing in pulmonary critical care medicine, and we have two amazing clinicians from Mayo Clinic. And as our case discussant, she is like no stranger to CP sober community. She's been like every possible sessions, like subspecialty, virtual morning report, IMG session. So she's in everything. So I'm sure you will know her name. So it's Dr. Alice Gallo. So Dr. Gallo, would you mind to unmute yourself and say hello to everybody and maybe tell us a little bit about why did you choose pulmonary critical care medicine?
Yeah. First of all, thank you for having me. You know how much I love the CP Silvers family, and you all know how near and dear to my heart Hafa was. So it's always a treat to come to the Rafael Medina specialty, subspecialty CP Silvers. The reason why I chose pulmonary critical care, well, let's be honest, the reason why I chose pulmonary is because it came with critical care. The reason why I chose critical care is because of the teamwork, and it's pure internal medicine. It's just like a little extra sick people that we have the privilege of care for. And I just love the team. I just really, really love working with the big team and just like doing things together. And pulmonary came with it. And I do believe being a pulmonologist makes me a better intensivist. So I love pulmonary too, but I can't pretend that I did pulmonary for pulmonary. I did pulmonary for critical care.
Okay, great. And it's true. Like every time I listen to Dr. Gallo talking about pulmonary critical care, she shows so much passion. And I think she always inspire all the fellow, everybody who worked with her says, you know what, go for pulmonary critical care. And I think Dr. Peterson is a good example as well. So yes, we have as our case presenter, Dr. Disha Peterson. She's also from Mayo Clinic, and she's a second-year fellow, pulmonary critical care medicine. So, yeah, Dr. Peterson, would you like to unmute yourself as well and let us know why you choose pulmonary care medicine?
So hello, everyone. I'm a little different, I think, than Dr. Gallo. So I like both pulmonary and critical care. So in pulmonary, I really, really like interstitial lung disease. I think as a resident, I really enjoyed the CTs. I thought they looked really cool. And then as I started to work with more of the patients at Mayo, I really appreciate getting to know them. It's such a chronic illness, so you really form such strong bonds with your patients. In terms of critical care, so I love all things organization. So I think for critical care, one of the best things is that you really have to be very organized. Dr. Gallo knows I love pens and different color pens. So I think critical care is a great specialty for that. But yep, she's showing you. So we bonded over that in the ICU. But really, what drew me to critical care is actually something a little personal. So my older sister was a preemie in the NICU and did pass away. And my dad, for my whole life, has always, really internalized that experience. And, he still has some trauma. Both my parents do from it. And so in critical care, a lot of times in MICU, we're not always saving our patients. So a lot of times we're really helping both the patient and their families accept, their loved one's impending death. And I really think of it as my service to humanity. And so that's really what I love about critical care. It's really, like Dr. Gal said, the team is amazing, but being able to connect with people, helping them start the grieving process and keeping them from, looking back 10, 20. My sister would have been 36 this year. So looking back 36 years and still having that trauma. So that's part of our goal in the team, is to really give patient and family centered care. So I feel like the ICU is a great place to to do that.
No, Dr. Peterson, thank you so much for sharing that. Yeah, that was so inspiring. Thank you so much. Wow, I think we're gonna have amazing session. And if you're both ready, I will have Gia, who is gonna be the scriber tonight. She's gonna share the screen. Let me see if she is able to share. Yes. So Gia, thank you so much for scribe. And we have Amo doing the teaching point as well. So thank you both for helping out in this session. So whenever you're ready, Dr. Peterson, you can start with the first aliquot.
Absolutely. So the chief complaint is we have a 37-year-old male that presented to one of our Mayo Clinic Health System's emergency rooms with a 6-day history of generalized weakness.
Great. Dr. Gallo, would you like to have more information or you want to give you your approach for this chief complaint, general weakness in
Yeah.
a 37 years old male patient?
So young patient with weakness, really very important. Like less likely is gonna be something chronic that is still has not been diagnosed. But again, I'm here bracing for impact. I just want to make sure that I don't know the case. I always like when I come to CPS overs not to know the case for two reasons. To model vulnerability. I might make a fool of myself online with a lot of people watching and saved for posterity, and I'm a-okay with that. And two, because I think it makes more fun. So 37-year-old, 7-day history of generalized weakness. First thing that comes to my mind is some kind of like acquired generalized weakness. So I would like to know more about history in the sense like, have they been anywhere? Have they traveled? What do they do for work? Is there anything new in their lives? Even simple things in pulmonary and critical care, such as like new cleaning products in the house, I would like to know. And any sick contacts, and obviously vital signs, very important for me, to me, like vital signs in someone who's young and saying weakness. Are they hypotensive? Are they bradycardic? Is it something cardiac that's going on? So those are my first thoughts.
Excellent. So that's a great jumping off point. So let me tell you a little bit more about him. So he has had this history of generalized weakness and associated dysphagia.
Oh.
2 days prior to his symptoms starting, he was spraying fiberglass insulation without wearing a mask. 2 days after spraying this fiberglass, he developed a sore throat, weakness, and difficulty swallowing. So
How many
yes.
days? 2 days. Okay. Difficulty swallowing, and the weakness.
And some things to note about this patient. So initially after the 2-day exposure, he did present to the ER and he was very lethargic, got naloxone. He does have a substance abuse history that we'll talk about. And he was sent home. 4 days after the exposure, he also came back to the ER, and this time he was having a lot of trouble swallowing. So the ER said, his vitals were stable, and they set him up for an outpatient esophagram. So he was not able to do that, and he has come back to our ER with, now we've talked about the 6-day history of dysphagia, generalized weakness, sore throat. And Dr. Gallo asked for our ER vitals.
Is it okay if I ask you a little bit more? When you say lethargy and things like that, was anything specific? Was it something like, did he have any seizures that were followed by lethargy? Did he have any specific neuro findings that he could tell? Was he able to swallow and was just having pain but still able to swallow?
So for the initial ER visit, he was not complaining of any of the swelling. To
Okay.
kind of go into what the ER thought at that time is our patient, from a social history standpoint, has an extensive history of both alcohol abuse and polysubstance abuse. So for this patient, in terms of his drug use, he was injecting fentanyl, heroin, and marijuana and meth, and he was inhaling both tobacco and marijuana.
But if this was going on for a while in terms of like the drug abuse, why now would he have different symptoms than
Mhm.
before? You know, so
Exactly.
I respect the thought process from our ED colleagues, but I would like to acknowledge the drug use and abuse. But
Yeah.
again, if he's been using this for more than 7 days and now 7 days he has something different with a new exposure, I'm gonna bet more on this new thing than before. Again, the drug abuse will come with complications in the hospital stay,
Yeah.
probably 2 to 3 days after he comes to the hospital, more from a withdrawal standpoint. But I would hate to just say like, this is what it is, you know?
And, I think you bring up an excellent point, Dr. Gallo. So, one thing, for those of you that have not done a lot of ER rotations, they have a lot of patients. They have to
Yeah.
assess their patients really quickly. And so sometimes, we get stuck in different schemas of, I have this patient that's a frequent flyer that has polysubstance abuse. Naloxone kind of made him less lethargic. He woke up. Um, that's what's going on. Another thing to note about this patient is he's a frequent, like he likes to sometimes leave after receiving care. So I think also what happened in kind of in defense of our ED colleagues is he got the naloxone and he wanted to leave. And, he wasn't necessarily quite sick enough on those first two ER visits where he was convinced he needed to stay. For the ER visit that we are talking about and where we're starting, his wife brought him in, and his weakness, his sore throat, and his trouble swallowing had progressed so much that he really couldn't argue with her at that point. And so that's kind of, where we have started. Um, I'm going to give her 1 second to catch up, and then I'm going to give you the vitals in our Mayo Clinic Health System ER.
So actually, Dr. Gallo, if I can ask you a question.
Mhm.
Previously you mentioned some like exposures, like
Yeah.
you would think about, oh, what kind of exposure? So in this patient, 37 years old, what type of exposure it comes to your mind when you think
Yeah.
about like general weakness?
Yeah, so things that I think about it are more like the viral things that can cause weakness. So any virus can cause like Guillain-Barré type of syndromes. So that was one of the things that I was thinking. Did he have a URI? Did he have anything recently like that? That's what I was coming from. And there are some viruses that happen here in our area of Mayo Clinic and Mayo Clinic Health System, such as like West Nile and things like that, that can present with neurological syndromes with infection. So I was thinking more of infectious things that could come with generalized weakness. And again, any type of meningitis, any type of CNS symptoms. So again, even encephalitis, usually encephalitis people show up more with increased sensorium, so like they're more agitated than anything. But even encephalitis can cause weakness depending on the virus. So those were the things that I was thinking, and that's what I was asking, like about recent sick contact exposures and things like that. That's where I was coming from.
Mhm. And Dr. Gallo, a following question to that thought. Do you think about any like occupation exposure or maybe like social history that it can come to your mind that can cause you another weakness?
Fiberglass is the first time I'm hearing about it, so I'm sure I'm gonna have to put like a little bit more thought on this. But um uh, uh like exposure in terms of work that would cause generalized weakness. can't think of anything right now.
I think we can just hold that thought and we can get more information from Dr. Peterson, and maybe that will come, to come together to more details. Go ahead, Dr.
So
Peterson.
absolutely. So what I will say to Dr. Gallo and all of you is this is one of our, very typical Mayo Clinic patients where you start in one place and you end up in another. So that's not giving you really any
Yes.
hints, but it's just kind of telling you that, we are always kept on our toes. And that's exactly what this patient did. So you are right under the past medical history. So I will say from that standpoint, really not much. This is not a man that goes to the doctor a lot. It's really just alcohol abuse and polysubstance abuse.
Just making sure, and you mentioned tobacco. Was he just chewing or was he smoking too?
So for his tobacco, he was just smoking it. He
Okay.
was not chewing it.
And any history of vaping?
By the time I met him, he was not in a state to tell me, but through looking in his medical record, no, he was
Okay.
not.
And the reason why I'm asking this is, again, vaping can cause a lot of problems in the lungs, from just like a pneumonitis to full-blown ARDS. And depending on what is in the vaping cartridge, people can get weak, depending on what it is there. So it's very hard for us to know what even is in this cartridge, the one that they're not commercially approved. That's all I have. Yeah.
Awesome. So just to kind of round out this section that you're on, he doesn't take any regular medications other than the illicit substances. He's not used any of them in the 24 hours prior to this third ER admission. Family history was not available, and no allergies.
Good. Dr. Peterson, would you mind to give us maybe the physical exam as well? So
So
Dr. Gallo can, yeah.
let's start with the vitals and the physical exam. So his temperature was 36.7. His heart rate was 102. His blood pressure was 123/68. His respiratory rate at the initial vitals were 20, and he was saturating 97% on room air.
Oh, wow. Okay.
This is to start with. So don't worry, we'll give you some more help.
I'm loving it. I'm loving it.
Yeah, there's a good twist. And Dr. Gallo did not take care of this patient. I checked his chart. So for an exam, so generally he looks older than stated age. He is disheveled and lethargic.
When you say lethargic, like if you say his name, will he wake up, or he's just there comatose?
So if you say his name, he'll wake up. But part of what I think why they were calling him lethargic comes down to his Hent exam. So he could not keep his eyes open. So that's just something to really keep in the back of our minds as we move forward, is that this patient just really, that was something that was documented, was that he was unable to keep his eyes open.
Did he have ptosis, or with help he could open his eyes?
With help he could open his eyes.
Okay. And was it effort ptosis, or he just had it?
He just had it.
Okay.
From a cardiac standpoint, his heart was regular rate and rhythm, no murmurs, gallops, or rubs. From a pulmonary standpoint, his lungs were clear except for bronchi in the right middle and right lower lobe.
Okay.
His abdomen was soft, non-tender, bowel sounds in all 4 quadrants. From a neuro standpoint, he really what people were talking about was generalized weakness at this point with no focal deficits. It seemed to be more in the upper extremities compared to the lower extremities. And like I've mentioned to you, his eyes, he was just unable to keep them open. And his speech was somewhat dysarthric. With this patient, I will say some of that may have been a little bit behavioral just at this point.
Okay. So now my thoughts include some things that could have been there before, and it just happened that this fiberglass thing without a mask is just like a red herring, and I'm okay with that. But like 37-year-old man with what sounds like a myasthenia-like type of picture. I have to think about some kind of lymphoma that is causing something in his mediastinum, or CNS involvement. And I also have to think about some kind of like, and let me rephrase, some kind of like mediastinum mass. Thymoma, lymphomas may come to mind, and thyroid disease as well. So I was, do you have a temperature for this patient when he first came in?
So his temperature when he first came in was 36.7. And I did want to add one more thing to our physical exam. His extremities have lots of wounds and track marks from his needles. So that's something that we want to keep in mind with this patient's case.
So if he was using needles recently and clearly doesn't protect himself during work, then we also have to think about endocarditis with septic emboli to his brain and CNS.
Excellent. So now we can talk about some of his labs when you guys are ready.
Can I ask for some, and that's okay if you don't have
Yeah.
them? I would love to get a CK. Again, myasthenic like syndromes or any paraneoplastic syndromes can come with rhabdo. I would also love to get an HIV test, because again, might be that he has been immunocompromised for a while, just didn't know, and smoked or inhaled something that was weird and just got himself out of control. And I would love a TSH with cascade if TSH abnormal.
So this
Dr. Peterson, if I may, before you read the lab, so Dr. Gallo, with this vitals and physical exam, if you see this patient in the ER, what would you do? What would be the management for this patient?
Well, right now he doesn't need immediate treatment of anything that I can see. Like with this vital signs and with this physical exam, I would just put the head of his bed at 30 degrees, and I would have aspiration precautions. Like initially, I would just like not have him eat. But like I don't see anything on his vitals that would make me think like, oh, he needs any medication right now. I wouldn't have IV access because again, things can change pretty quickly. But other than that, I would not go for intubation. I would not go for anything in terms of like, I don't even want to give him antibiotics at this immediate time, because again, it could be something else. Sepsis is not the first thing that is in my mind right now, to be honest with you.
And I think that's excellent.
Thank you. Thank you so much, Dr. Gallo.
So to give you some more information, Dr. Gallo, his CK was normal at 50. His TSH was also normal.
Okay.
You asked me, remind me what else. So TSH, you asked me about HIV, which was negative.
Okay.
He did not have HIV.
Okay. Very helpful.
To keep us moving a little forward, I want to give you, since we're going to review his ICU course that was a couple days, I want to move forward on these labs. So his CMP and chemistries, the only thing that was abnormal is his total protein was a little high at 8.1. Otherwise, I didn't write out the chemistries, but everything on the screen was normal. His white blood cell count.
Was his total protein, do we have labs from before? Is this new?
I don't remember off the
Okay,
top
that's
of
all
my
right.
head,
That's all
but
right.
in the meantime, I'll look.
That's all right. So like just to share, an elevated total protein always makes me always puts like some kind of malignancy higher in my differential. More because you're telling me that their renal function is okay. If they had an AKI or things like that, then could still be from an AKI. But with normal everything else, malignancy goes higher on my differential.
From the standpoint of his blood counts, he did have a white count of 17.4 with a left shift of neutrophils were 14.69, and this was our first, first set of labs of many.
Okay.
His hemoglobin and platelet counts were normal. And there's a couple other things that I would like to give you just to kind of help out. So his lactate was 1.8, so less than 2 is normal. His CRP was elevated at 239. Our ED colleagues also checked a Tylenol, ethanol, and salicylate level. Like I mentioned, he had not been using any substances 24 hours before coming, so those were all normal.
Okay. So again, an isolated white count that is high makes me think about more hematological malignancies, to be honest with you, specifically in such a young man. CRP of 239 is so non-specific. So many things can cause elevated CRP. And another thing that when white count is isolated like this, I always think about C. diff infections, because C. diff infections can cause an elevated white count like this. And very severe C. diff infections do come with an ileus actually, and can even come with ogibis. But usually they don't come with weakness unless people were having like terrible diarrhea. And then again, if he was dehydrated, he would have other lab changes, lab abnormalities. I'm still puzzled about why he ended up in the ICU though.
We're getting there.
Oh, okay.
Promise.
So again, so far he's very sick. I will not send him home,
Yeah.
but but so far I'm like,
So let's take us a little step towards our imaging. So remember, we talked about how he had bronchi in the right, middle, right, lower lobe. And so we have some CT image. They actually got a CTPE. I will tell you, since I'm only giving you a few cuts of it, that it was negative for PE, but I want to show you and I apologize if you hear some barking in the background.
we love your dogs.
Yes, I have two that are creating some drama back there, but from my standpoint, we could show Dr. Gallo our CT images.
And just again for teaching purposes, I would not at all for this man. Can you all hear me okay? Because my microphone.
Give me 1 second. Close my door.
Dr. Gallo, can you see the images?
I can see the images.
Mm-hmm.
He does have a very dense consolidation in his right upper lobe that is also in the hilum on the images on the left. The shape of it, it's worrisome to me that there's something endobronchial actually, because because it's too perfect, and the margins are too perfect. So I'm wondering if there's something in the bronchial, in the lateral segment of the right upper lobe and the hilum, and he also has post-obstructive pneumonia, on the right side, and on the left side, in the left lower lobe, there are some ground glass infiltrates that again make me think this history of like dysphagia. He might have aspirated already, and generalized weakness. So I would say he needs a bronchoscopy next. And my malignancy and paraneoplastic syndrome is going higher on my differential, or like in good Mayo Clinic fashion, this is a ball of fibers that that is closing the airway. I don't know.
So our ER colleagues, the read came back as severe consolidation with right middle lobe and right lower lobe volume loss. And he was started on, he was given cefepime and Cipro. And then at this point, as they're trying to figure out a disposition, his oxygen saturations got worse. So he was saturating in the 90s and required about 2 liters to come back up. They also gave him, they at this point saw him more as a sepsis picture. And so they gave him 2 liters of normal saline. They drew blood cultures. He received cefepime and Cipro. And his disposition, like you mentioned, he doesn't really sound like an ICU patient, but his disposition was actually to our inpatient pulmonary service.
Okay.
So he was coming in the chest service.
I like it.
So let me give you some more information. So he arrived to us at Mayo Clinic, very sick. So like we talked about, he started off not requiring any oxygen, saturating 97%, decompensated a little bit in the ER, required 2 liters. When he arrived to Mayo Clinic, he was unable to speak. He was hypoxic to 70%. So when he got to the floor, and this was, they put him on 15 liters non-rebreather, which is the highest amount we can go. He only came up to 87%. And so immediately on arrival, a rapid response team was called. Our 3rd-year resident showed up, and he was what Dr. Gallo likes to call a scoop and run. So he looked like he was not protecting his airway, and we were ready to receive him. The other thing I wanted to mention about the RRT was that the nurse was unable to suction, but when the RT came, they suctioned a large quantity of blood. So no one quantified it in milliliters, but there was a large quantity of blood that was suctioned. So at this point, we had this patient that was, from a respiratory standpoint, stable when he arrived in the ER, decompensated a little bit, and then en route got worse. So when he arrived to Mayo Clinic, we are concerned about hemoptysis. We are concerned about him protecting his airway.
Yeah.
And we are concerned about saturation of 87% in a 37-year-old that does not have a history of lung disease.
Yeah. And the rest of his lungs, like besides that dense consolidation there, the rest of his lungs look pretty good. So so there's no other reason than that for him to have this dense consolidation. And by the time he started having hemoptysis, do we have coags for him? His platelets were normal. So do we have coags for him by the time he started having hemoptysis?
That was normal from
Okay.
what I remember. I did not write them down.
Because one thing that I want to make sure that we talk also about, any infection, any lung infection, if someone has abnormal coagulation profile, can cause hemoptysis. And it's not something like malignant, is not something, the inflammation of the lungs with abnormal coagulation cascade and ability can cause hemoptysis.
So now I finally get to meet this patient. So he came to the ICU, was intubated by me, and we immediately bronched him and did a bronchoalveolar lavage. So what was documented by me was in the right lower lobe, in the anterior segment, he had purulent secretions.
Okay.
Another thing to note that was really the major finding is that he kind of had some pooled secretions in his trachea. So like we said, he really wasn't protecting his airway, and now we're starting to see some drooling / pooled secretions.
Okay.
At this point, we are saying that our differential diagnosis was community-acquired pneumonia, inhalational injury. And I have already told you guys, we were considering HIV, just like Dr. Gallo brought up. That was negative. We found that out later in his course.
Can I ask you something?
Mhm.
Did you notice anything at this point on his skin besides the needle marks? Anything on his neck, anything up here that we could think about? Ludwig's angina with the drug use history. When you bronched him, anything on his like throat that you noticed, like were his was his were his tonsils big or anything like that, that could be caused the drooling instead of a weakness?
No, so
Okay.
none of that. So other than as I look back through our bronch documentation for him, it really was that right lower lobe purulent secretions that we noticed, but really nothing else abnormal in his throat, nothing else abnormal on the left side of his bronchial tree, nothing else abnormal on the right side either.
Just so the people listening don't forget, again, if you have a Ludwig's angina, or if you have an abscess in your tonsils, you can have inability to swallow saliva, and it's not necessarily weakness. This is
Mhm.
mechanical. So just want to make sure we talk about that.
And as you brought that up, one thing I did want to bring up too, and this is a really good point that you brought up, is that he had pretty poor dentition. So
Okay.
that is something that could have, a Ludwig's angina is not a bad thought in what I have told you so far. And so again, that should, the other parts of it, like we didn't really notice that much like soft tissue swelling. His tonsils looked okay. So really nothing there, but he did have poor dentition.
Okay.
At this point, we are treating him with Vanc, cefepime, and prednisone for severe community-acquired pneumonia. We're giving him IV thiamine because he has a history of alcohol abuse. As his MRSA swab came back negative, we just de-escalated him to cefepime.
Okay. So MRSA nasal swab was negative. This is not MRSA. And besides purulence, did you see anything in the bronchially?
No.
Okay.
So I think the comment you made earlier about considering, did he have fibers endobronchially? Was there something in the endobronchial tree that we weren't seeing? We did not see any of that. So other than the purulent secretions, nothing really was noted. So now I'm going to kind of tell you a little bit about the different ICU days. And I think we're going to start to make some progress on what was actually going on with this patient. So there were, what is causing our weakness. So like I mentioned to you, on ICU day 2, we repeated a bronch because, the patient was following commands. He was on minimal vent settings. What really was causing us to consider, what was really giving us pause towards extubation was the pooled secretions in his throat. Like he really just did not seem like he was protecting his airway. When I spoke to him, he would respond, but otherwise his eyelids were very droopy. He couldn't keep his eyes open. And at this point, we, on our physical exam, noticed something new that I haven't told you. He had bulbar weakness. So this is not something that was
So he
documented.
was not coughing.
Mm-mm.
Okay. So then bulbar weakness, 37-year-old man, did he have any muscular fasciculations?
From what I remember from my exam, no. And he did have a weak cough, Dr. Gallo. Like it wasn't no cough now that I'm looking at my notes. But the bulbar weakness this was the first time that it was documented, that it was noticed. And so that's something I want you to kind of think about.
So I would, and he was following commands, right?
Mhm.
So I would, at this point, then get a brain image,
Mhm.
whatever you like,
Mhm.
I would get an LP at this moment more for protein.
Mhm.
Thinking about again a CNS syndrome, a
Mhm.
medullary syndrome,
Mhm.
and we have to get the myasthenia antibodies. I'm blanking on their name now, but like we have a panel. But yeah, there's a
Mhm.
panel for everything in Mayo Clinic. We would just
Yep.
type myasthenia and the antibodies that we need will pop up so we can choose. Those are the ones I'm talking about.
Excellent. So you are right on track. So on ICU day 3, we obtained a CT head and neck. He had extensive dental caries, but it was negative for epiglottitis. He had a retropharyngeal effusion, but that was from my intubation. So really nothing exciting.
Okay.
At this
No
point,
abscess, no nothing.
no.
Again, with this IV drug use, that's the first thing I think, like you have to think about some kind of spinal abscess. Nothing.
Nothing.
And the brain looked okay.
The brain looks okay.
And it
So
was a CT, not an MRI.
So I will tell you that we did obtain an MRI brain later that was really did not show anything. Lumbar puncture was not, I mean, I didn't write it down, but again, our neuro colleagues got involved at this point. And so they were unimpressed by the MRI brain and lumbar puncture. And I want to tell you a little bit about their physical exam because I think that's going to kind of help us get a little
Okay.
bit more information. So
Okay.
our neuro colleagues felt that he had bulbar weakness, he had generalized proximal muscle weakness, temporal wasting, facial muscle weakness, weakness in his neck, it was flexion greater than extension, decreased muscle tone is in his extremities, but not flaccid paralysis. He also had diaphragmatic weakness. That was one thing they noticed. Hypoactive deep tendon reflexes, a negative Babinski, and his sensation was intact.
Did family show up at this point?
Yes, so family was involved the whole time.
Did they mention anything about him choking before? Did they mention anything about him having some pneumonia before? This is ALS.
No, they did not. And let me tell you what, at this point, we've kind of have two diversion things going on. So we have a pneumonia that we're treating. We think there may be a component of inhalational injury. And our neuro colleagues are now working up the weakness because I think
Yeah.
kind of to
I
kind of,
think
yeah, go for it, Dr. Gallo.
I think the pneumonia is a consequence of the weakness now.
Mhm.
I don't think it's the cause.
Yep.
So my cancer and infectious things go lower in my differential as the cause of it. And I'm thinking this is like this guy has a ALS, was highly functional for some. What's concerning to me is the bitemporal wasting,
Mhm.
bulbar symptoms, and proximal weakness with the diaphragm, because that's pretty consistent with ALS and ALS like syndromes.
Mhm.
And what I think is like came to a point that again, 37-year-old, he was probably compensating until he couldn't anymore.
So their differential was a little different. So they thought this could be an atypical presentation of Guillain-Barré. Now we've been talking about that. They brought up an HCV infection,
Yep.
listeria, rhomboencephalitis, an infiltrative leptomeningeal process, or the last thing they mentioned was myasthenia gravis. So
But
now let me tell you about my testing a little more, just to
you
kind
told me the LP was normal.
Yes, so the LP is normal, but at this point, so they made the differential, and then we got the MRI brain, LP, and an EMG after. So this
Okay.
differential was made before. So that's why you asked me the questions, I gave you the answer.
Got it.
Yeah.
Because like listeria would be a very abnormal CNS.
Mhm.
Guillain-Barré will be a very abnormal CNS, very high protein. Listeria is also very known for causing very low glucose and very high white count.
So what I want to give you now is the test that I did not tell you was our EMG and our nerve conduction studies. So he had a presynaptic defect in neuromuscular transmission.
So it's myasthenia.
So they're actually, the myasthenia antibodies were actually negative from what I remember, and that's not what he
Ah.
had.
Okay.
So they had two differentials from this presynaptic defect, and their two differentials at this point were botulism and Lambert-Eaton myasthenic syndrome.
Yeah, I remember. Yeah. From what though? Botulism from what?
So the botulism is what they felt like was the most likely cause of his weakness. And we felt that his botulism was in the setting of wound botulism from his IV drug use.
Huh. Do
Yeah.
we have botulism in Minnesota?
So there have been some cases and there were around the time, and that's what kind of sparked this. And so we actually, talked with our ID colleagues who agreed that this was most likely a
Love it.
situation of, I told you this is a true Mayo Clinic patient where you start in one spot and you end in another. And so they agreed with wound botulism, and they actually talked with the CDC, and our patient was given the antitoxin.
Nice.
He was tested for the toxin, and I'll tell you now that he was negative, but he has been seen by neuro since then, and they think it was a false negative because the patient has he improved.
Improved. Okay.
Yes. So in our final diagnosis for this patient was actually, pneumonia in the setting of likely this fiberglass inhalation, and his weakness that really wasn't documented well from the beginning of the ER visits. Like I said, this was a third ER visit that led to admission. That was really kind of the giveaway, was the bulbar weakness, or EMG with the presynaptic defect, the fact that there were a few cases of botulism, believe it or not, and it was Minnesota and Wisconsin at the time,
Okay.
and the fact that he got better with by being
Yeah.
given the antitoxin.
Did you guys do the paraneoplastic panel regardless for because it's like myasthenia like, right? Like it's
Yes.
myasthenia like ALS like kind of have to young guy.
I'm trying to remember if we did. I do not think that we did, because I think that they were very convinced that this was botulism. And at that point, neurology had, figured it out from their testing, and ID got involved, and we really, really felt that this was the correct diagnosis, and the patient has improved since then.
I love it.
Wow, such an amazing case. Oh, wow, there's a lot of twist and turn. So Dr. Gallo, would you like to share with us some maybe 2 or 3 teaching point from this case?
Absolutely. Just like I said, first thing that I said, like I want more history, because again, in the middle of the case, I'm like, oh, maybe this is some kind of cancer or something like that, but very unlikely that something new in a young person is going to be something sinister. But again, we have to think about so history, very important. And physical exam in this case, very important, because Dr. Peterson did commented on the IV sites that didn't look super healed. So potential port of entry, and that's why I was thinking like endocarditis and things like that. And epidemiology, very important, because again, I don't think I've heard botulism being a thing in Minnesota. So again, like now even though the botulism can be anywhere because of cans and things like that, but like someone who was like pretty benign except for some drugs, I would not have thought botulism. I know someone wrote at some point on the chat about botulism, and I'm like, Minnesota botulism. But good job whoever wrote that. And again, just because because I always think about these things. I would love to have ruled him out for this being a perineoplastic syndrome, because it can still be something in his belly that we haven't found, or something like that. But teaching points, history is very important. Number one. Number two, location is very important as well. And number three, physical exam. Keep doing physical exams, because physical exams change. Don't count just on what you read on the chart. Go to bedside and do physical exam yourself. And I'm going to do a 4, just a good plug for pulmonary and critical care, because you just saw, like, we talked about so many things in one ICU admission. So it is a specialty that literally gives you everything, and
Oh,
allows you to take care of patients and their families, like Dr. Peterson said.
yes, thank you so much for the teaching point. And actually, I'm going to ask Dr. Peterson, would you mind to share with us your experience when you were taking care of this patient as well, so we can learn from you as well?
Yeah. So one of the things that keeps me going, and why I love working at Mayo, is that our patients humble us every day. So I think that, like I mentioned, this was the third ER visit that led to an admission. We were thinking this is just a severe community-acquired pneumonia and inhalational injury. Our pulmonology brains were really, really excited. And, like Dr. Gallo said, the physical exam and the patient history are so important. I will share with all of you that I'm a patient myself. And, looking back at my own journey dealing with cancer, my history and physical exam led to the diagnosis. And this patient, the same exact thing, that his history and physical exam are what really led us to botulism. We would have extubated him and he would have failed. He could have really gotten sicker. We could have, lost our airway in him. And so the most important thing that I want all of you to take away from this case, and why I wanted to bring it to all of you guys, is really this, is that our patient's story and exam really give us the diagnosis. They give us so much more. And in a world where, as I was a resident, I feel like, you're so bogged down by the information. You really want to know every little thing, and you think the computer will tell you. It really won't. There's nothing better than bedside. And one thing that Dr. Gallo really helped me with as a first year fellow is she wouldn't let me go sit at the computer. We had to walk around together. We examined every patient together. And you told me, you were like, if there's something you need to know, you can log in. There's a computer in every room. And we did. So sometimes we had a question and we would look together at a specific lab. And number one, it was more efficient. It was more fulfilling. And really, it helped us give our patients better care. So if you take away anything from me from this case, is to always be at the bedside, to always be doing your own history and exams. If your patients can't talk to you, like in this case, talk to their family. Never substitute what other people are writing for your own work, because he probably did have bulbar weakness that was not documented. And I will be vulnerable with all of you in the spirit of Dr. Gallo and say, neurology is not my favorite, and I don't love their physical exam, but man, was I humbled in this situation. It's a really good plug to make sure that, you're working on your physical exam skills. You're thinking about those, ones that you're not as good at, and really seeking it out, because this was a huge, he's 37. And so he could have had a much worse outcome than he did. So really, this was just, one of our typical Mayo patients, kept me up at night, kept us going. And Dr. Gallo, I think you discussed the case excellently. I didn't give you a lot. I knew I was going to kind of twist things around. And I think we reviewed a lot of internal medicine.
Yeah. And again, we reminded people that critical care is internal medicine. So it's the best.
Yeah, thank you. Wow, thank you, Dr. Peterson. That was so humbling to hear.
Love it.
And I think your reflection is something that we're gonna think about a lot. And of course, Dr. Gallo, every single time she comes back for a session is amazing. So, and so
You're all too
inspiring,
kind.
so,
You're
so
all too kind.
inspiring. I'm so sad to say that we have reached to the end of our session. So thank you both so much for joining and to share your wisdom. And thank you everybody for participating. Thank you, Amo and Gia for scribing and doing the teaching points. So have a good night, and I will see you tomorrow.
Thank you for
Bye.
having
Hello,
us.
everyone. Thank you for having us.